Okay, folks, let's make a start. So, welcome to this week's report out. Two really good updates to hear from this time, and so we'll go straight on to do the meal service, and then straight into the dietitian's presentation from Emma, and then we'll do our Q&A at the end. So I can see James is on, so we'll come straight over to J15 Meal Kaizen Event 60-day report out. Thanks.
Hello, my name is James Barraclough and I'm the process owner for this Kaizen event and the ward manager on J15. So our project is tag named Empty Plates Not Empty Tummies. We came about this project, I'll summarise because I've been here obviously a couple of times before, looking at poor nutrition of patients, been contributed to pressure ulcers, increased length of stay, deconditioning, and also poor patient experience. We did some team building events, and we asked the KPO team to support us with getting the team on board with telling us what they wanted to improve and helping them to do that themselves. So one of the projects that was chosen was around meal times and making that a better experience for patients. So this is where we came to this from. So during the project was set over 2 days, we came to restructure a meal service, one that was effective based on the baseline data that we'd got and addressing the issues that we'd found. We got together a meal service structure that addressed all those areas, looking at putting staff in zones to ensure that everybody was supervised during meal service. We looked at reducing the time of the meal service and removing obviously waste steps that were in there. And we also had some other ideas to go from after we've got the meal service perfected. So the data that we've got at 60 days shows we've maintained the progress that we made quite early on, really, in the process. So we've at 60 days, we've still got 6.8%, or 60 days, sorry. Yeah, we've got 6.8% of full plates left at the end of meal service, which we acknowledge that there's more work to do there, which I'll talk about later on. But other than that, we've maintained the same progress that we've made at 30 days. So 100% of patients receiving hand hygiene before meals, no patients having the tables not prepared, 100% of patients getting food that they asked for, 100% of staff engaged in the process. We've continued to keep the lead time of the meal service reduced by 55 minutes from what it was before, and the time that patients were waiting between being prepared and receiving soup down 55 minutes as well. So one of the next steps that we wanted to look at was around moving this onto the dinner service, not just the lunch service. So this is some data we've got around that process from moving to both meal services. And it's very similar really to what we've got from the lunch service, although there are less steps in the dinner service. The baseline data very similar to what it was for lunch, and the targets remain the same, although we wanted to reduce the dinner service down to 60 minutes. We have a very similar number of plates left, which is something, again, I'll speak about later. And other than that, in terms of hand hygiene, in terms of tables being ready, patients getting what they ordered, and the morale of the staff is exactly the same. But we managed to reduce the tea time meal service from 120 minutes down to 45 minutes, which is a 63% improvement. So on to the next steps of where we're at now. So it's a two-pronged approach from here. So one point is looking at rolling out the meal service that we've embedded on J15 onto the other elderly wards on level 8. But which is mainly being spearheaded by the facilities team. In terms of the nursing staff on J15, what we're looking at now are the quality of the food that we've got and the choices of the food that the patients have got. So we collected some baseline data on that only 39% of patients were eating less than half their meal, and 64% only 64% felt like the portion size was right. Only 59% felt like there was an adequate choice of food on the menus. Of the people that felt the portion sizes weren't right, 50% felt the portions were too large and 50% felt that the portions were too small. At this point, none of the patients were using other menus, and only 40% of the patients knew about the menus. So our target data for that is that 0% of plates will be less than half eaten. 100% of patients will be happy with the portion size. 100% of patients will be happy with the choice of food. Obviously, the too much, too little will be 0 because the 100% will be happy with the portion that they've got. We didn't set a target for patients choosing alternative menus because we felt as long as the other metrics are good, doesn't matter what they're choosing because that's what this is all about, the choice of what they want. And that 100% of patients would know that there were different menus out there to choose from. So what we've done in terms of the menus is we've introduced a board to go at the back of every patient's bed, which you'll see on the left, which goes hand in hand with what you see on the right, which is basically laminated menus all in one book, so one in every patient area, so one in every bay and one in every side room, that the nursing staff can show to the patients and they can have a browse through and look at what they prefer and then give them the choice to decide which menu they would to order. So then they would record that on the board, and then the patient and the housekeepers then, when they're going around giving out the menus, know which menus to give them, and that would be changed on a daily basis. We also looked at what portion sizes the patient wants and reflecting that on the board also, so that the housekeepers can record that on the menus when they're filled in. This was a much bigger job than we anticipated because we ran out of laminating sheets. So we've not actually got all the books together yet. So I don't have any data to show the impact of this yet. But obviously we are ready to roll that out as soon as this is completed. And we're about probably 95% complete with the booklets. So we're hoping to start this next week. But in terms of the menus that we looked at the core menu, the finger food, which is more dementia friendly. We looked at Easy Chew for patients that have dental issues. Obviously anything swallow related would have to go through salt, but for dental issues we could do that. We also included vegan and gluten-free on there because we know that patients are more conscious of their diets, even if it's not to do with allergy. And then obviously multicultural options on there as well. So the next steps from here is obviously to roll out the lunch model on the other 3 elderly wards on level 8. Unfortunately, that's been put on a back burner at the moment because they've had some managerial changes within the estates and facilities team. So until that's fully handed over, they haven't started that. But in terms of the menus, like I say, we are ready to roll it next week and then start the data collection from there. We've also, myself and Claire have talked about organising another meeting with the team members from the original project because we feel like we've got the choices there for the patients, but probably in the way that it's ordered and recorded could be improved. So we are going to organise a recap meeting there for us to look at other options of how we collate the choices of the menus and make sure that that's there. Thank you for listening.
Brilliant, thanks, James. Really good to hear that. I'm sure there'll be lots of questions, but really lovely to see the progress of such a patient-centred piece of work and a real engagement of compassionate care for the team as well. So well done. So we'll go on to Emma. Can I see you on the call, Emma?
Hi, yes, I am here. I'm not sure if you can see me. My talk leads quite nicely into what James has just been discussing, actually quite similar topics. So yeah, my name is Emma Smith. I'm one of the clinical lead dietitians over at the LGI. I'm presenting today because I attended the Leeds Improvement Method course to learn about sort of where to start when doing an improvement project on a bit of a bigger scale. As part of the course, I decided to attempt to address one of our sort of dietetic team's rocks in our shoes, that the dietetic plans that we sometimes recommend aren't always implemented every day on the ward. So dietitians advise on nutritional care for patients during their admissions, and it's often in the form of recommending a menu or a supplement to the patient or ward staff. Examples that James has nicely talked us through there are the multicultural menu and snack menus and things. So the dietitians in our team noticed that we can sometimes recommend a patient a menu or to the ward staff, but we might come to review a week later, 10 days later, and the patient hasn't received the correct menu, or they may have received it once or twice and then didn't receive it on the third or fourth day. So we wanted to try and improve the consistency of the patients receiving the recommended dietetic care plan. So as part of the project, I completed a root cause analysis and noticed that the dietitians are a very small team. There's not very many of us in comparison to the wards that we cover. So we're not always on the wards to support implementing those changes. There are multiple stakeholders involved in actually getting the right menu to a patient, such as ward housekeepers, nursing staff, support workers. And so I identified the root cause of this sort of rock in our shoes as the communication between shifts and between different staff members. When I looked at the current state, I discussed with dietitians how they currently update ward teams and found that sometimes dietitians were adding on to the whiteboard in the kitchens directly, sometimes speaking to ward staff members, and sometimes documenting in clinical notes, but there was no sort of consistent way that everyone was doing the same thing. So I collected data to establish a baseline of how many patients required an alternative menu versus how many patients received the alternative menu. Initially, there was only really small numbers of patients when I tried to look at one ward. So I actually changed approach and looked at patients who were under the dietitian and our overall caseload. But that then meant that multiple wards were involved in the project. I completed Gemba walks across the cardiac and TRS wards at the LGI to discuss with staff and housekeepers how they currently know which menu patient needs. And again, that was variable. So wards use the whiteboards to identify the alternative menus, but there was variable responses in whose responsibility it was to update the whiteboard, and if patients move bed or change menu, who communicates that between different wards and patients moving. And all wards then, when I tried to discuss with them around the best way of communicating this information, all wards felt that the ward handover form, the nursing handover form, was the best way for nursing staff to know, and then nursing staff could update the housekeepers and update the whiteboards then as well. Then we got some unanticipated consequences as part of that. So the ward teams felt that the handover was the best way to communicate this information. But then when I discussed with the dietetic team that consistently adding to ward handovers could be the best way to communicate within the shifts, it meant that was another thing for then the dietetic team to remember, that was adding to our time around our documentation, and another thing to remember as part of the process of assessing a patient when we're also doing other things like updating the clinical notes. So as part of the project, we decided to start to add to the handovers within the project as we were collecting the data, rather than asking the dietitians to do it as a standard. We started doing that as part of collecting of the information. So we collected data on 4 occasions, and prior to consistently adding to the handovers, the data collection, we had between 1 and 6 patients requiring alternative menus, and the range was received was between 0 and 100%. And then following the change, we collected data on 3 occasions, and the range of menus received was between 0 and 50%. And this was between 3 and 6 patients. So unfortunately, there was no clear improvement, which could be due to the small numbers of patients, the large numbers of wards involved, or that it may be that this wasn't the best way to communicate the changes to these ward staff. So what went well for me, sort of learning about Gemba during the Gemba walks, I got to find out a lot more about what actually happens within the ward processes, the challengers and factors and stakeholders that can be involved in what seemed like, when I started, I felt like that was quite something small to start with, and then it developed into something much bigger. I learned more around how nursing staff communicate between shifts, and I had great support from the dietetic colleagues in terms of collecting the information and adding into the handovers once we started to do that as part of the data collection. And avoiding mental valleys. It's interesting that James has brought up his sort of how your project has gone, because initially I thought, oh, we'll develop a sign, we'll develop something pictorial. And when I spoke to our ward staff, that wasn't something that they thought would be useful. They felt that the handover would be better. But now with my results, I've got lots of ideas of going forward and sort of redoing things. So that will lead into the next slides then, if that's okay. So next time, when I've thought about what I would do differently, as I said, although I thought this was a small change, in order to test the change, I'd aim to focus on one clinical area and one ward and just stick to that one ward, even if the numbers are small. My key learning around it was the unanticipated consequences. So I've learned about how a small change in one area and something that might improve in one area can have a negative effect on other teams, because that meant it would have been more time consuming for the dietitians on a day-to-day basis. And I have implemented that into other areas of my work where things have been suggested, just in general our caseload, and whenever it comes to things like engaging all the stakeholders before making any decisions, I've already started using that key learning. And moving forward, I think there's some wider discussions around if we do want to add to handovers, whether we reduce the length of time we're documenting in other areas, if that's not useful. And in terms of doing another LIM project, communicating the vision. So sort of at the start, I think I kind of went into this as I'll try an improvement project and I'll give this one a go, but I think I'd sort of pick something that I can then communicate the vision and why we're doing things in a bit of a better way next time. And I think more Gemba walks with the ward housekeepers around how the processes work on the ward and focusing on one area, like I say. So focusing in on that one ward and maybe coming with ideas like James has suggested around the alternative menus to see if they are things that the teams would want to consider in the future. So thank you for listening to my talk.
Brilliant. Thanks, Emma. Thanks for that. Really good. And I think some really good, honest reflections as well of the challenges you faced and some of the learning, which of course is all great to think about how, and so really grateful for you sharing that with colleagues. So really good. 2 linked presentations, some really good topics to get some questions on. So can we open that out? Can I just ask, whilst people are waiting, for James, I wonder, do you get any sense that there may be a contribution in terms of things like length of stay by ensuring people are getting better meals, better nutrition during their stay? Is there anything that you might think is helping with that?
I think it would be difficult to quantify, but in terms of KPIs on the ward, sorry, our metrics, 2 areas that they look at within the nutrition area are around food charts and tables being ready, which is what we took from the things that we learned, and they've on the last metrics were 100%, which is the first time we've achieved that. So in terms of the overall metrics that we're achieving, it's showing a positive impact. And obviously nutrition is something that is integral to recovery. So I suppose we could probably look at capturing something to see if that's made any difference. It's not something that I've really I thought of, but yeah, that would be something good to look at.
Thanks, James. Rabina?
Thank you. Sorry, James, I didn't manage to hear your presentation because I was late from another meeting, but it's recorded, so I will listen to it because I think nutrition is quite a key fundamental, isn't it, for our patients in terms of their recovery. But Emma, your presentation is kind of really struck a chord with me, and I'm just wondering, I know you've managed to speak to the housekeepers, etc., but in terms of engaging with the nurses and getting their input and kind of understanding how they can support you with this, did you come up against any barriers, or have you, is there, what else can we do to support you? Because I think this would be really good to be shared at a nursing forum so we can get that kind of real engagement, because this won't be happening just in these few areas, it will be happening elsewhere, as you say.
I think, at the time, so I've actually changed roles. So at the time I was leading on cardiac and TRS. So I linked in with the ward managers that I have quite a good rapport with and knew quite quite well. But things like the other nursing staff on the ward, I probably didn't engage with them as much. I'm now leading on neurosurgery, so I think in terms of focusing it on one area and engaging that ward team, I'd be comfortable enough with that. And we've got some more dietetic time coming in to the cardiac and TRS sort of from a dietetic perspective. So hopefully that might mean that in the future we can sort of focus one person working in one area. But yeah, I don't know if you've got any other ideas. That would be great. I'm not sure what other forums would be useful to engage the nursing staff.
Great.
I'll get back to you on that, Emma. I've got your name down here, so I'll be in touch.
Thank you.
Great. Thanks, Robina. Jimmy?
James, fantastic. Well done. I've put in the comments, but I think I want to say it as well. Despite the operational pressures, just to maintain what you've been doing up there is so impressive. And to go beyond maintaining it and continue with your plan to spread it and to look at what next. So credit to you as the leader of that team, but also all the other people involved. So great to hear. And yeah, I know Katie in our team's been behind the scenes supporting you, so that'll stay. Well done. Keep at it. Thank you. Emma, first time I've heard that. Great to hear. And Robina stole my question, which was what help might you need to get a little bit more traction with the teams on the ground? Because as you say, you're a pretty finite resource. You can't be everywhere all of the time, but the stuff that your expertise can help our patients is really valuable. So how do we help that to be there even when you're not? But I think Robina got to that question and is on it. So that's great. Thank you.
Thanks, Jimmy. James?
Yeah, two fabulous presentation, guys. And James, as Jimmy said, great to see the sustaining and spreading the improvement. So well done. Emma, I really liked your reflections and particularly the piece about communicating the vision and I guess developing a shared vision and how you go about that and how you involve some of your key stakeholders in that, why this is important and what we therefore need to do about it. I think is a kind of critical learning for how to succeed in improvement. So yeah, really brilliant to hear your reflections and how you found the experience. Thank you.
Thanks, James. I can't see anyone else wanted to come in. So yeah, two really great presentations. I think some really good themes coming out of this. I mean, just again highlighting the variability that we obviously have in a big organisation and the opportunity there is to improve that. But I think both presentations, and I know James, you talked before in yours about the importance both of kind of getting people to understand the why we might be undertaking improvement work, and then thinking about how the communications around that are so important for any piece of work for busy staff who are kind of under pressure just delivering the day job. And I think, Emma, thinking about that, how staff experience change, and thinking about how we support people with something that might seem very positive from one point of view, but actually can have a less positive impact, and thinking about that. And I guess that standard work theme, which comes across many weeks when we're listening to teams reporting out, is really important, I think, and just continuing to work out how we can standardise where we can. So thanks, James and Emma, again. Two really great patient-centred presentations. Well done for keeping them going. We'll look forward to any further developments. Thanks everybody for joining, and we'll close Report Out there. Thank you.